Good morning and good afternoon, everyone, depending on where you are in the world. Clarteis is really pleased to present this webinar on excimer 308 and its efficacy on vitiligo and psoriasis. If you've got any question during the presentation, feel free to write them in the chat. I will hold next slide, if possible. For this presentation, Professor Giovanni Leone will be doing the presentation. Professor Leone is a senior consultant dermatology at the Israelite Hospital of Rome. He's also scientific coordinator, CEO of two clinics, one in Rome and one in Milan, and is the dermatology academic director of ISD. Dr. Leone is widely recognized for his expertise in photobiology, photoprotection, clinical phototherapy, and the treatment of vitiligo, psoriasis, and photodermatosis in general. So Professor Leone, thank you very much for being with us today. And it's your turn.
Thanks to you. I'll go with the first slide then. Thanks for your kind introduction. So it's very difficult for me to cover all the aspects of phototherapy in one day, in 1 week, maybe a month is not even enough. So I will try to focus on the main points of interest for us as dermatologists that practice phototherapy and in particular targeted phototherapy. So okay, sorry, because the slides move forward a little bit slowly as compared to when I give the input. So phototherapy is a medical treatment that uses light. So phototherapy is not only UV, can be visible light, can be any kind of light to treat various skin conditions. Now we are focusing on the treatment with ultraviolet rays. This is what we call normally phototherapy, but the phototherapy in its whole encompasses also other wavelengths. So the main goal is to expose the skin to specific wavelengths of light that achieve therapeutic effects. So, of course, it has to be administered under medical supervision and can be highly effective in improving skin health and appearance. Meaning, what was known was heliotherapy, the therapy with the sun, and so the therapy with this was the first form of phototherapy at the beginning. And after this, what has followed is the exposure with UV lamps, artificial sources. It started 40, 50 years ago with the older lamps, mercury arc lamps, and lamps without a selective wavelengths. And now we see the advantages of using the selective wavelengths. That is the concept of targeted phototherapy. And then it has moved forward with the introduction of PUVA therapy with solar lens, UVA phototherapy, UVA1. You can see here on the slide that is long wave UVA. And the most recent technique, most recent in the beginning of the 90s, was the introduction of narrowband UVB, that now is the therapy of choice for many diseases of the skin. So you see here a recap slides of all the types of phototherapy that we have and we have had in the past, because some of these are not used anymore. UVC never used because it damages the skin. UVB, broadband UVB 290 420 is not used anymore now, nearly abandoned, and in favor of the narrowband UVB that represents more than 90% of the phototherapy equipment that now we have. UVA is very important for performing PUVA, was very important, and now also UVA1 high dose, especially high dose UVA1, is important to treat some diseases like atopic dermatitis, scleroderma, lymphoma, etc. So we have two possibilities. We have the whole body exposure that was used in the past, was the most well-known kind of phototherapy. It has been used for broadband UVB. It is used nowadays for narrowband UVB, oral PUVA, bath PUVA with immersion in a solution of Sorolens, broadband UVA, UVA1, and phototherapeutic balneotherapy. These are the treatments that we use with total body exposure. So, on the contrary, what has been interesting in the last 20 years, when at the beginning of the year 2000, the targeted phototherapy was introduced with the first publications on the excimer laser, the 308 excimer laser, is based on two concepts. The possibility to irradiate selectively some areas of the body without damaging or exposing surrounding healthy skin, and the possibility to use a monochromatic wavelength. In this case, we are talking about 308 nanometers, that has selective and different, slightly different effects from the common wavelengths of narrowband UV. So you see, these are technical details to explain how is generated this wavelength of 308 nanometers. So this is very close to the 311 nanometers, that is narrowband. So monochromatic excimer light 308 is a super narrowband UVB, I will define, and technically, it can be produced by lasers and lamps, and it is based on the production of excited dimers. Dimers are sealed in a cavity and then are excited by the light, and then there is the wavelength of 308 that is emitted. Of course, in the case of the laser, it's a little bit more complicated. The beam is collinated, so this is specific of the laser. But let's say that in very simple terms, here you see the technology for producing the excited dimers that are the xenon chloride molecules are hit by the energy, and then we have the excited on the right. We have the dimers that are excited, and then they deliver the 308 light, 308 nanometer light. So this is roughly these are concepts of photophysics, but it's roughly the concept. As I was saying before, it is important to state that excimer light is equivalent. We have done also a clinical study to excimer laser, but maybe there's, in the case of the laser, the beam is more collimated. But we have on the other side some drawbacks, like the high cost of the machines. We had in our institute, we had at the beginning the excimer laser, one of the most well-known excimer lasers that was distributed in the world. We used it for many years. And then we moved to the excimer phototherapy with excimer lamp, or focused on 308 nanometers. So you have seen now the machines have gone through an evolution in these 20 years. We started with big machines for excimer light therapy, and now we are arrived at the stage where we have small machines that are very handy, are very user-friendly, that can be transported, light, not heavyweight. And so this is very important for the recent progresses, because it helps the dermatologists to have an instrument that they can use easily and transport it when they need to transport. So the principle is exactly the same. Some devices, like the device on which we are talking today, the XFX, are one of these kind of devices. The weight is very low and it's very easy to transport it, and the emission is also quite important. So there is no possible drawback as compared to big machines. So technology has done a lot of progresses, and now we can use these smaller machines with the similar results to the big machines that were used in the past years, and similar results also compared to the excimer laser. These are the advantages. You see, very fast. The time to deliver a dose is very short as compared to the narrowband UVB classical conventional phototherapy with UV tubes. It can be used on selected areas. It's ideal for children. This is very important, and it's safe for all skin types, and the side effects are minimal. So let's go to the limitations. So, of course, as you imagine, it's impractical for larger body surface. So you use it also for selected areas with a limited skin surface affected. And it has no effect on surrounding skin, on unaffected skin. So maybe some systemic effect of immunomodulation, etc., that we have in systemic phototherapy is not recognized in this case. And some patients do not respond to the treatment, especially in this case, it may be that the indication is not good because the lesions are too extended, at least in my practice. So you see excimer versus laser. I already talk to you about some comparison studies. So the wavelength is the same, 308. You have monochromatic and coherent collimated beam in the laser, and monochromatic non-coherent in the lamp. But this is not important for therapeutic purposes. So absolutely, there is no difference in clinical results, or very slight difference. So you see the advantages are the same, but the defects, the cons, are mainly due to the high cost of the lasers, the need to refill the laser with the xenon chloride as a laser bottle, gas bottle that is very expensive, and so a lot of maintenance that makes things particularly impractical for use in everyday practice. So the mechanism of action of both is due on the immunomodulation, the inhibition of antigen presentation, inhibition of T cells, and the induction of apoptosis. There have been some studies at the beginning with the laser, but the concept is the same for light, that demonstrated clearly that the wavelength of 308 is more effective in inducing T cell apoptosis in vitro as compared to the narrowband 311 nanometers conventional phototherapy. So this is very important, and I stated at the beginning that there are not only differences in size and in area of the skin that can be treated, but also differences in the quality of the irradiation. And this is due to specific effects of 308 nanometer excimer light wavelengths. So you see that there is an increasing liberation of endothelin by keratinocytes. There have been also some many publications dealing with the selective effects of the 308 nanometer wavelengths, and it has been demonstrated that all these effects that have been seen are peculiar to the 308 nanometers excimer laser or lamp wavelengths as compared to the conventional narrowband UV. So this is very important to keep in mind. So these are the indications of the different phototherapies. As you see that, of course, monochromatic excimer lamp falls into the category of narrowband UVB because it's a narrowband UVB. So the indications are the same. So just a couple of words on our center. We have been treating since many years a lot of patients, mainly, let's say that nearly 80% of our patients now are represented by vitiligo patients. We have also psoriasis in second line, 12%, and then we have a few cases of other different diseases in which you can have important results with monochromatic excimer light treatment. This is my colleague, Professor Andrea Parovidolin, works with me. We are born as a staff in the San Gallicano Institute, let's say 20 years ago when we founded the phototherapy unit. Then we have moved recently to the Israeli hospital, and now our center is mainly dedicated to vitiligo, but we treat also other diseases. So let's talk about our clinical protocol now with the excimer lamp treatment. So the session frequency in vitiligo is 2 times per week. Some cases in psoriasis, we irradiate also 3 times per week. That is better. But for vitiligo, absolutely, I would say 2 times per week. The initial dose can be variable on the basis of the areas that are affected. Here you see, of course, you start from the very sensitive areas, and then you go to hand and feet that can tolerate even 400 millijoules square centimeter. This is quite high. So on the basis of the area, you will start with the definite doses that you can find on some tables like this one. we have the possibility to increase the dosage at each treatment session, and this can be done if everything is okay. You don't have erythema. At the starting period of the therapy, of the treatment, you can increase also by 50 millijoules square centimeters, or you can increase on the basis of the percent. But here, in this case, it's much more simple. If there is erythema, you will not increase. If there's not erythema, you will continue increasing, and you will see on the basis of the table how much is the increase. In some cases, sometimes it's easier, we do increase of 10% as compared to the first dose, and then we always go on for vitiligo with 10% until the asymptomatic erythema can develop. And I insist on this, on my experience, that you have to induce erythema. If you irradiate in vitiligo and you don't induce erythema, it will not work and repigmentation will not be seen. So it's not correct to give doses that are too low, because otherwise photoadaptation is induced, the skin gets hardening and resists to UV, and you will never get the repigmentation. Very important, there are some substances that you can use in combination with phototherapy in vitiligo, with excimer phototherapy and conventional phototherapy. These are all the drugs that you see here. We have been using tacrolimus, steroids, and now at last we have the ruxolitinib, the topical JAK inhibitor, that shows very nice results in combination with all kinds of phototherapy. Narrowband, total body narrowband UVB, and also very interesting results with excimer-like phototherapy. So you see that here there are other possible combinations with physical therapies. There's peeling or deepitalization with CO2 lasers. We have used microneedling also, and we can do this in the same session or in different times. We have done studies with microneedling together with the excimer lamp, and we have had also results in increasing the outcome of phototherapy. Here you can see the clinical results in our patients. You can see after 17 sessions in these patients, together with ruxolitinib, that makes things much faster, and very good results at 17 sessions. So this one also with ruxolitinib after 26 sessions, it's quite, let's say, rapid as compared to excimer alone or ruxolitinib alone. So this is for us now a very good combination phototherapy, JAK inhibitors plus targeted phototherapy or conventional phototherapy. You see also in this case good results after a limited number of sessions. Here you can see a patient with skin type 5. Here there are some signs of hyperpigmentation. I will talk in a minute about this. And also here with ruxolitinib, very good results. Also here, other results in vitiligo after 25 sessions. Always our case are serious with ruxolitinib. Here we have some cases without ruxolitinib. You see the results are less prominent. And now let's move to psoriasis. Just a word on hyperpigmentation in vitiligo. It's important to protect surrounding healthy skin to avoid hyperpigmentation, if it's possible. It's not always possible, but when you want, when you can protect with templates or with very high sun protection screens. So here you can see the protocol for psoriasis is completely different, has to be more aggressive, because also in this case, photoadaptation can be seen and can make the treatment unsuccessful. So we irradiate 3 times per week, like in narrowband, conventional narrowband UVB. And you see the initial dose for a thin lesion is 1 MED, and for a thick lesion is the double of the MED. So we have an idea on the MED with tables or with determining the MED in non-affected skin of the patient. And then we can look at the erythema. If the erythema is not so prominent, we can increase. And if the erythema is very sustained, or there is very high, even near to sunburn, we postpone the next session, we avoid the session, etc. I must say that there are also some quite aggressive protocols based on 8 times the NED or 16 times the NED that have been published in the literature with excimer laser and excimer lamp, that this is up to everyone on his experience to try. Sometimes it can be very quick, but it's also very dangerous in terms of side effects. So this is not a common protocol to recommend. It can be based on, if you have a great experience, you can try. Otherwise, the conservative protocol is better. You see some cases with exposure with the Exiplex combined with calcipotriol and betamethasone, in this case 1 to 2 times weekly, because we had also the topic with very good results. You see after 9 sessions, here we irradiated with together with the narrowband UVB cabin. So a combined phototherapy on the difficult areas, a reinforcement with the 308 nanometers excimer lamp, and at the same time, the patient had irradiation on both the body with the cabin, the total body boost of narrowband UV. So here you can see a very nice example where the irradiation with the narrowband UVB boost cabin total body had been done, and only on one area as control on the left side, the lesion was irradiated also with Exiplex. So this clearly demonstrates that this combined addition of targeted phototherapy can increase the results on difficult areas. Potential side effects in vitiligo, as you see on the right, this is a photo from the previous treatments many years ago with the laser. So an aggressive treatment can be very damaging for the skin. You can have blisters, you can have perilesional hyperpigmentation, like I told you before, and persistent erythema. But apart from this, effects linked to too high irradiation, too high dose, there are not other important effects. So this can be treated by local steroids and by suspending the treatment and restarting from a lower dose. Here you can see the strategies to reduce these side effects. You can, with the Exiplex, you can easily use templates or reduction tips to attach to the lamp, to the handpiece. So you can select a smaller area. And so this is very important when you want to irradiate a small lesion, that you can reduce the area that is irradiated with a template or with a mask or something like that, and in order to try to avoid irradiating the skin outside the lesion. So you have a series of tips and templates that are available to do this. So in synthesis, it's time this kind of treatment is time saving, is comfortable, the instrument is portable, user friendly, and it makes, I think it makes a very good choice for a practice. Maybe in a hospital, you can afford also to have bigger machines, etc. But in a practice or in a clinic, sometimes this is the best solution to have good results, good patient compliance, and let's say a very good ratio of cost advantages. So as you see, targeted phototherapy can use in combination with total body, and we've seen some examples. This is a very good indication when there is, especially in psoriasis, and it's a very effective choice for vitiligo, especially in children or limited cases of atopic dermatitis. And of course, it reduces the cumulative dose of UV. So this is very important to reduce and minimize the carcinogenic risk of the UV therapy. So I hope I tried to cover everything quickly, but I think I have underlined all the main aspects of this kind of phototherapy. So now I'm ready. Thank you very much for your attention, and I'm ready to listen to your doubts or questions.
For those who have more questions, feel free to write them in this box. So the first question that we have is, what will be your recommendation for resistant cases of acrofacial vitiligo with almost no response to excimer light as monotherapy treatment?
Well, fortunately, this is a quite rare event. In the case we find no response in these acrofacial forms of vitiligo, I would suggest to try to keep a low level of erythema in any case without burning. And I would try to focus the attention on the possible combination therapies in countries where topical JAK is like our country is available, or ruxolitinib, but maybe this would be the first choice. But I'm very happy also with topical corticosteroids and with TCI, calcineurin inhibitors. So I think in this case, we should try to get the help from a combination therapy. And another combination therapy that probably I have overlooked because I presented quickly is what we do in our center, the association with systemic antioxidants that improve the tolerance for phototherapy and act as inhibitors of oxidative stress that is recognized as one of the causes of the multifactorial hypothesis of pathogenesis of vitiligo. So this also can be an approach. So in my opinion, good combination therapy and moving very carefully, increasing the dose, but not too much, because a burn in these cases can be more harmful than used.
And in this case, would you keep 2 sessions per week?
Yes, yes, because one session per week, even for maintenance, maybe sometimes we use it for maintenance, but I think it's not enough to stimulate repigmentation, one session per week.
Okay, it's good that you're talking about maintenance because we've got another question related to this topic. How do you ensure maintenance of the results achieved in vitiligo and in psoriasis once the desired results have been reached? How do
Yes. So
you
we
ensure it as
must
well?
distinguish between psoriasis and vitiligo. I told before, I have just stated now that maybe maintenance treatment for vitiligo is not recommended. In psoriasis, in many cases, like for conventional narrowband UVB, some maintenance could be useful in order to keep the results. Let's say for 1 or 2 months, I usually in some difficult cases, I usually taper the frequency of sessions. So after, rather than stopping at once, I continue with 2 sessions per week for, let's say, a couple of weeks. Then I do 1 session per week for 1 month, and then I stop. For psoriasis, this is a good approach. For vitiligo, unfortunately, we don't have really reliable data on the percent of let's say the pathology showing again and repigmentation disappearing. So I'm not sure, and in the literature there is not agreement on the fact that continuing with 1 session per week, as we said before, for vitiligo, or even worse, 1 session every 2 weeks, like I heard someone does, in my opinion, is absolutely useless, because for inducing repigmentation, you have to be continuously stimulating the erythematous reaction in the vitelliginous skin. So once you have obtained repigmentation, you should use topical or systemic treatments in order to maintain the treatment. But in my hands, doing one treatment sometimes, let's say once a week or once every 2 weeks, has absolutely doesn't make sense.
Okay, thank you very much. Then we've got a question related to the current contraindications related to excimer. Are there any contraindication?
Well, I think I showed a slide. I don't know. No, maybe I showed a slide on side effects and not on contraindications. Let's say that from a general point of view, contraindications are the same as for systemic phototherapy, for whole body phototherapy, but are less restrictive. So maybe sometimes we talk about previous incidents of skin cancers in skin cancer, or even in some cases previous melanoma in the family or even in the patient. I must say that in some cases, even with being very careful, when there has been some preceding episode of non-melanoma skin cancer, or in some cases also melanoma, and you need to irradiate in a very limited lesion, just say a very localized form of vitiligo, of course, on areas that are not sensitive, like the hands or the feet, sometimes you can do short treatments. But of course, this is based on the experience of the physician and how much you feel comfortable. But targeted phototherapy allows freedom of action that is very different from the irradiation on the whole body. So even for photodermatosis, for lupus, for other photosensitive disease, in some selected cases, in very limited areas, targeted phototherapy can be used with a lot of caution, but it's not excluded 100%. But this is my personal opinion. So I'm telling you my personal opinion, and you have to be careful and evaluate case by case.
Of course, and thank you for sharing your experience. We've got another question that is, in case of hyperpigmentation around the lesions on the healthy skin, how do you treat to fasten the discoloration to go back to the normal skin color?
Of course, as you can imagine, in vitiligo, I will never try to provoke depigmentation or discoloration of the hyperpigmentation, because this would be a wrong approach, and we could induce even Kobner phenomenon, or we can get back other lesions of vitiligo. So my approach is just to wait. I always explain to the patient that after maybe 1, even sometimes 2, 3 months, the hyperpigmented area around the vitiligo lesions will slowly get back to the normal color, and this is in the majority of the cases. But I would never apply any depigmenting agents.
Okay, thank you very much. We've got another question related to the body restrictions area. Are there any? Or can you treat it in all body areas with excimer?
Well, probably also this, we didn't have time to talk about this in detail. I would say that the folds, like the groin and under the breast in the females, especially in persons that are overweight, in the folds, it's not a good indication to treat. The areas where there are hair, normally it's not the contraindication, but it does not, the treatment does not give the good results. So unless you completely shave, it's not advisable to do the treatment on the areas where there are hair. And another thing is that some cases in vitiligo, they say where there is a leukotrichia, sometimes the lesion do not respond very well, but it's not a reason to not try the treatment. But I would say yes, the folds and in the areas that can be particularly sensitive, with being very cautious also on the eyelids. But I would say really not to use it, maybe only, and of course I don't recommend on the genital areas. I always recommend to protect the genital areas.
Okay, thank you very much. And last but not least, we've got one more question, except if other people have some and want to write them in the chat.
Sorry, I didn't hear the question.
Sorry, I was saying, from what age do you start treating patients with an excimer?
Yes, well, this refers to the general indication of phototherapy. There are publications that have been done many years ago, and it was stated that it was quite advisable to start treating children starting from 4 or 5 years of age, because they could respond to instructions, they could listen to the parents, etc. And there's no specific risk of the skin of the infant related to narrowband. This was related to narrowband UVB phototherapy, so also total body. So I suppose, even if there are not publications on excimer lamp, that as the treatment is targeted on the area, even in smaller children, let's say 2 or 3 years old, if the children can keep quiet and they can collaborate. I think you can treat small areas of vitiligo, being very careful with the dosage to avoid burns that would be absolutely disturbing. In this case, I think you can start treating very small areas also starting from 2, 3 years old with targeted
And
propagation.
what would be your recommendation in terms of dosage for children?
Well, I think there is nothing wrong starting with the 50 millijoules per square centimeters. Just be careful because maybe if it's sufficient to induce erythema, just stop, or eventually, instead of doubling the dosage, you can just increase by 10% or be a little bit slow, more slow in the progression. But otherwise, I don't think there is a huge difference in the erythematous reaction between the child and the adult. Not that much.
Okay, great. Thank you very much. We don't have any more questions so far. Let's wait a few seconds if some people want to write
Yeah.
something in the chat or want to unmute to ask a question, but I think we are almost done.
Yes, they can always send some mails or something that we can answer. Uh,
Yeah.
yes.
Okay. I don't think we have any more questions for the moment. Anyways, thank you very much, everyone, for attending this webinar. And thank you, Professor Leone, for hosting this great webinar. It was enlightening, sharing your experience. If people have other questions, feel free to contact us. We'll be more than happy to address them by email. And I wish you all a good day or a good evening, depending on where you are in the world.
Thank you very much to Plaque Days for your assistance and for inviting me to do this. It's a pleasure. And I hope everyone has been happy. And I'm absolutely ready to answer to any kind of questions in the future if they need.
Thank you very much.
Thank you very much, Dr. Leone.